Hello. Today we're going to talk about the conservative and post-op management after rotator cuff tears. Again, one of the commonest surgeries to be performed in shoulder is going to be a rotator cuff repair. So let's find out how do we do it. Understand how the management is going to be different for a full thickness tear. We need to understand what is different in these patients as compared to a regular impingement or a shoulder pain patient. Here we have found out that people who have a full thickness tear have an increased scapular humeral rhythm. So the amount of scapular compensation is excessive. Impingement patients also show more scapular compensations, but we find decreased upward rotation or an increased anterior tilt. Here we find an increased scapular upward rotation. The scapula is compensating because there's so much pain at the glenohumeral joint that the scapula upwardly rotates more. There is also a very classical sign is that there is a superior migration of the humeral head. Now, in impingement patients, this may or may not be true across studies. There are studies which have found that the humeral head moves up, and there are studies which have not found any difference. But in cases of full thickness tear, yes, because the lack of stabilization provided by a rotator cuff and because of excessive pain, there is a superior migration of the head on the glenoid. There is an overall reduced range and strength. Of course, there is no reduction in passive range of movement. And most people, when they are diagnosing full thickness tears, the differential diagnosis is adhesive capsulitis or arthritis because, again, we have a lack of mobility there. But here, the lack of mobility is associated with the excessive pain that the patient comes to us with. And we find that if we give any pain relieving injection, there is restoration of even kinematics. So all the compensation that is being happening at the scapula also reduces as soon as the pain goes away. So here we definitely know it's not a cause, it's a compensation mechanism. The classical clinical presentation of somebody who's had a tear, if it's not an acute traumatic tear, and if we're talking of degenerative tear, we're talking of a patient who's slightly older, and the person presents to us with pain, excessive pain at night while sleeping on the affected side, pain with overhead reaching activities. There's, of course, a positive painful hour, and there's a weakness involved. That is, that you would find active contraction to be weaker. If you ask a person to do a strong contraction, it is painful also, and it is weak also. So you need to differentiate it with adhesive or arthritis, where even passive range of movement is reduced. Here, there is no reduction in passive range of mobility.